Hi, everyone. Thanks for rejoining us. And we are back with Dr. Klompas, and he's going to talk to us here about the approach and management to bacteremia. Thanks, Dr. Klompas.
Okay, great. So let's go for it. So I'm still me, and my disclosures are still the same, but here is our outline for this talk. So we're going to talk about gram-negative bacteremia, one drug or two. What's the preferred drug for an ESBL? Duration of treatment. Gram-positive bacteremia, what's the best drug for MSSA, MRSA? What do you do if you have an elevated Evanco MIC? Does your patient with bacteremia need to get an echocardiogram? Once you're ready to treat, you should place a PICC line or a midline. And how about treating with orals? Is that adequate or not? So let's go for it. As before, we'll start with a case study. So a 64-year-old woman is admitted to your hospital with high fever and altered mental status. She has a remote history of cardiac arrest, coronary artery disease, and congestive heart failure with a low ejection fraction, which she has an implantable defibrillator placed 2 months ago. She also had elective cataract surgery 2 weeks ago. She has a history of recurrent UTI secondary to ceftriaxone-resistant E. coli. Your exam is notable for lethargy, anasarca, and tachycardia. Her vitals, so she's febrile at 102.3, her heart rate is fast at 110, her blood pressure is low at 80/60. She's breathing 32 times per minute, and she has a low oxygen saturation, 88% on ambient air. You go ahead and order a CBC with differential, comp metabolic, lactate, UA, procal blood cultures, and a chest X-ray, and you decide to start antibiotics. Good choice. The question is this. This patient's very sick, right? They're hypotensive, they're highly febrile. Do you really need to get blood cultures before we give antibiotics? Is it not more important to simply get antibiotic inside this person? And the answer is that timing does still matter. Here's data on the impact of your timing of blood cultures relative to antibiotics. So this is an analysis of timing of blood culture draw relative to antibiotics in 325 patients, suspected septic shock. And if you got blood cultures before antibiotics, your yield was 30%. And if you got blood cultures after antibiotics, your yield was 20%. In other words, even a small difference in your timing of your blood cultures, you got them after antibiotics, you've dropped your yield by about a third. And that was true even with just a 30 to 60 minute difference as to when you got the blood cultures relative to starting antibiotics. So it really does matter in terms of yield to try to get your blood cultures first. Now, if we are going ahead and start this patient on empiric therapy for gram negatives, should we start one drug or two? And we actually have a randomized controlled trial talking to this question. 600 patients with sepsis randomized to meropenem alone versus meropenem plus moxifloxacin, and actually no difference in 28 mortality rates for either sepsis or septic shock. The message is over here that so long as you have a susceptible isolate, it makes no difference if you have one drug or two for sepsis or septic shock. The instances in which it might make a difference is if you have a potentially resistant pathogen. So again, the indications for double coverage, you can do it either to increase the probability of coverage or to increase antimicrobial kill. What this study tells us is that it makes no impact in terms of patient outcomes with regard to antibiotic kill. But there might still be a benefit if the patient has a resistant pathogen. The one instance in which people have really spoken about is there value to double coverage is for patients with Pseudomonas bacteremia. Historical teaching was you double cover for Pseudomonas. In fact, that's not been borne out to show the test of time. Here's a prospective study of 674 patients with Pseudomonas bacteremia, looked at monotherapy versus combination therapy, and you can see no impact on the cumulative probability of death at a month. What did make a difference was inadequate treatment. So if you got inadequate treatment, you didn't cover the active pathogen, that was associated with a higher mortality rate. So again, the indication for adding more than one drug is if you worry the patient has a resistant pathogen and you need to broaden your coverage, but otherwise it makes no impact. On the topic of resistant pathogens, we heard that this particular patient had a history of E. coli UTI with an ESBL, an ascendant spectrum beta-lactamase producing pathogen. Now, if you do treat an ESBL, can you trust susceptibilities that come up inside your computer? Can you use any drug that's marked as susceptible? Well, there was a randomized trial looking at this question, comparing piptazo, so piperacillin tazobactam versus meropenem for ESBL E. coli or Klebsiella. These are patients with bacteremia, so 391 patients with positive blood cultures for E. coli Klebsiella resistant to ceftriaxone who were randomized to piptazo versus meropenem. The outcome was 30-day mortality, and outcomes were better with meropenem. So it does, for a serious infection with an ESBL, the recommendation is to use a carbapenem. You can see over here, the meropenem was associated with a lower 30-day mortality rate, a lower rate of microbiological relapse, and in fact, a lower rate of secondary infections with MDROs or C. difficile. So let's go back to our case study a bit more. You begin your empiric therapy. You should decide to use vancomycin because of the presence of a new AICD, so you worry about gram positives. Meropenem because you're worried about a patient might have urosepsis given their history of recurrent UTIs and ESBL E. coli. And one day later, the patient looks a little bit better, but it's still febrile. Your ProCal that you ordered comes back and it's 0.18, which is pretty low. You call up the lab to say, are your blood cultures growing anything yet? And the answer is nothing so far. And so my question for you, does that low procalcitonin actually rule out bacteremia? Do you have enough information to be able to stop worrying about bacteremia? So this is cool. Here's some data on the sensitivity and positive predictive value of procalcitonin for the presence of bacteremia from analysis of 75,000 patients with admission, blood cultures, and procalcitonin testing across 65 US hospitals. The results here are divided by procalcitonin value. So our patient would fall into this category over here. And you can see that the sensitivity for a procalcitonin at a very low threshold is actually pretty high. And the higher the threshold, not surprisingly, the sensitivity drops off. But the positive predictive value is low. And this speaks back to our conversation in the prior lecture that procalcitonin values are really follow a very wide distribution. And just because you have a bacteria present doesn't necessarily mean that you have a home run, always high procalcitonin, or vice versa. So you can have lots of other conditions that can raise your procalcitonin. So the bottom line over here is your sensitivity of procalcitonin is pretty good, but it's not perfect. The positive predictive value is actually pretty darn low. So our patient with their low procalcitonin value could still very much have a bacteremia present, and the positive predictive value here is less than 20%. Now, we're getting a bit frustrated here waiting for the results of that culture. And our real question is, do we need to continue the vancomycin or not? Is Staph aureus really in the picture here or not? And so my question is, how long do you need to wait to be confident that the blood cultures won't grow Staph aureus? Here's the data on that. This is yield of blood cultures amongst patients with MRSA bacteremia as a function of time. And you can see here, the message is that by 48 hours, just about everybody who's going to have a positive blood culture of Staph aureus will be positive. So if you have negative blood cultures at 48 hours, the likelihood of Staph aureus bacteremia actually is very, very low. Here's our case study continued. Just you're about to give up hope on finding an answer about the cause of pathogen, the lab pages you. The patient has one positive blood culture bottle. Gram stain shows gram-positive cocci clusters. You wisely suggest Staph aureus. You arrange a follow-up set of blood cultures to be drawn. And the question is, have you nailed the diagnosis with just one positive blood culture? What is the significance of a single positive blood culture for Staph aureus? Do you have to worry about endovascular infection, or is it likely to be just a contaminant? So here's actually data on this. The significance of one positive blood culture for Staph aureus, 534 patients with Staph aureus bacteremia, 22% of whom were single positives, 78% had multiple positives, and this is from the Mayo Clinic. And look here at the rates of endocarditis and other outcomes as a function of single positive blood culture shown in red versus multiple positive blood culture. What you see over here is that multiple positive blood cultures, no surprise, is associated with a higher probability of endocarditis and worse length of stay and mortality rates. But the key point over here is that even with a single positive blood culture, 4%, so 1 out of 25 of those people actually had endocarditis. So the teaching now has really evolved to you cannot blow off any positive blood cultures for Staph aureus. They all deserve treatment and investigation. Now, we have grown up in a system where we often have to wait 2 to 3 days before we get susceptibility testings. And isn't there a faster way? So there's a lot of interest in this particular question. And it's part of the field that has been using PCR, molecular-based diagnostics to look for resistance genes to try to get that answer faster. And part of it have looked to using more traditional methods, but trying to augment our sensitivity for antibiotic susceptibility by using microscopy or other kinds of computer-aided systems. So I'll give you one example of that. This is a rapid antimicrobial sensitivity testing mechanism, where basically you're using a microscope to be able to see the impact of antibiotic exposure to pathogens on their growth in near real time. And This is just one way you can get rapid antimicrobial susceptibility. As we said, another possibility is molecular techniques. But as with molecular techniques for pneumonia diagnosis, the kind of results of these are similar. So I'm going to give you the results of this study, but really this is echoed by what you'll find if you look at the data on molecular diagnosis as well, which is that if you're using one of these rapid diagnostic susceptibility methods, you will get your susceptibilities a lot faster. In this case, 40 hours faster, so a day or two faster using a rapid methodology. And that does decrease overly broad treatment results. So you're able to more quickly narrow the patient and provide narrow appropriate therapy. And likewise, make sure the patient is on effective therapy. So you decrease the rates of ineffective, non-active, inappropriate regimens, but no difference in mortality rates. And again, that's been our finding again and again with these molecular methods. They get you an answer faster. They make it more likely you have appropriate treatment on board, but they don't actually change patient outcomes. As we said before, from a laboratory perspective, that's actually still a win. And so this is the way that the field is moving. A bit of a self-interested question over here, if I may. Do you need to bother getting an infectious disease consult in a patient who has Staph aureus bacteremia? And there's actually data on this showing that that ID consultation is indeed associated with better outcomes for patients. So this is an analysis of 37,000 episodes of Staph aureus bacteremia in the VA, and they looked at the factors that were predictive of better outcomes, so lower mortality rates, and no surprise, getting appropriate antibiotics, getting an echocardiogram so you can know if the patient has endocarditis and modify your treatment course appropriately, and ID consultation, because we'll make sure you get the above two. Looking at more detail at a similar sort of question, this was 1,700 patients with Staph aureus bacteremia, again, looking for predictors of better outcomes, aka lower mortality rates, and they flesh out for us a few additional factors associated with better outcomes. Again, adequate antibiotics comes first, but also source control when that is possible. An echocardiogram, its value, again, echoed in this particular study. There was a pun, thank you. And getting follow-up blood cultures and choosing the appropriate duration of therapy. Those are the factors associated with success. Now, if the patient turns out to have MSSA, so methicillin susceptible Staph aureus, what's the best treatment? Can I keep this patient on vancomycin, or am I better off narrowing to something like cefazolin, nafcillin, oxacillin? So here's the data on this. This comes from a retrospective analysis of VA patients with positive blood cultures from SSA, so methicillin susceptible, about 5,700 patients. What was nice about this was that they divided the population into their empiric treatment course and their definitive treatment course. And what they tell us that if the empiric treatment course, it doesn't actually matter if that's vanco versus beta-lactam, no impact on outcomes. So that's kind of reassuring that if you think that there's a possibility the patient might have MRSA, you're not going to pay a price for using empiric vancomycin. However, once you actually have susceptibilities and you're at the definitive treatment phase, where you can provide tailored treatment that direct to the patient's actual pathogen, then it does make a difference. In that case, beta-lactams like cefazolin and nafcillin are superior to vancomycin. You get better outcomes with a beta-lactam to treat MSSA compared to vancomycin. So as soon as you get susceptibility testing back, do go ahead and switch over to a beta-lactam. If you are choosing a beta-lactam, what should you use, cefazolin or nafcillin? And the answer is, in terms of outcomes, they're pretty similar with maybe a little caveat. But in terms of tolerability, cefazolin is clearly preferred. Multiple studies demonstrate to us that the rate of adverse effects of cefazolin, shown here in red, is lower. So less rash, less renal dysfunction, less liver function abnormalities, less early cessations of antibiotics. So cefazolin is your preferred MSSA drug if you can use it. In terms of outcomes, interestingly enough, there does appear to be benefit to cefazolin as well in terms of 30-day mortality and treatment failure. So cefazolin is associated with lower all-cause mortality, but no difference in treatment failure or relapse. So again, another vote over here for cefazolin as your preferred agent. Now, the caveat is these are observational studies, and because we preferentially give cefazolin perhaps to less sick patients, this might be an artifactual finding, so take it with a grain of salt, but it certainly shows no harm associated with using cefazolin. Now, there's been a lot of interest in this question of could you use ceftriaxone for MSSA? And we still are uncomfortable with that for inpatients. But by the time the patient has been stabilized and they're ready for discharge, could you send the patient out on ceftriaxone and take advantage of that much, much more convenient dosing regimen? So ceftriaxone for patients with normal renal function is given 3 times a day. Nafcillin and oxacillin given up to 6 times per day. So ceftriaxone, by contrast, only given once per day. So for outpatient, it's a very attractive potential agent. Here's some data on that question over here. This was predictors of readmission in patients receiving outpatient antibiotics after being hospitalized for MSA bacteremia. And here were some of the predictors of readmission. So more serious infections associated with prosthetic joint infections, central lines, recent hospitalizations, staying in the ICU. But your choice as to whether you use cefazolin, oxalin, nafcillin versus ceftriaxone made no difference. So once the patient's stabilized, they're ready for discharge, ceftriaxone might in fact be a reasonable discharge regimen. Now the patient continues to improve. She's more alert, less confused. Her temperature curve is normalizing. And you review her blood cultures for remission. This is where things have landed. Turns out she has 4 out of 4 bottles, and they're positive for MRSA, so medicine-resistant Staph aureus. And yesterday's blood cultures are negative thus far, and you have another set of blood cultures pending. Now, it turns out this is actually becoming increasingly unusual. If you look at surveillance data for MRSA across the US, what you'll find is that MRSA is becoming less and less common, whereas rates of MSSA infections are pretty steady. This particular analysis comes from the VA. There's similar data from other systems showing similar findings. So MRSA is happily a less common pathogen. The converse of this is that PSSA, penicillin susceptible Staph aureus, is actually becoming increasingly common. In my hospital, 20% of our Staph aureus isolates now are penicillin susceptible. But in our particular patient's case, we did recover MRSA. So let's talk about what our treatment options are. And in this day and age, it still remains vancomycin as our agent of choice, given duration of experience with it. And it's just very good long-term track record. There's concern raised about patients who have high MICs, though, to vancomycin. So inhibitory concentrations of 2 or more. Sometimes people use 1.5 or more. And some data suggest that might be associated with higher mortality rates. So over here, look at this meta-analysis over here. The odds ratios for death was 1.6 in patients who had a high vanco MIC. But there's been a lot of sort of question about this result because other meta-analyses do not show this particular finding. This more extensive meta-analysis found no difference in outcomes depending on the function of vanco MIC. And this fascinating study, I think, sort of cracks open the issue over here. These were patients with MSSA, so methicillin susceptible Staph aureus bacteremia, and they were all treated with a beta-lactam. In this case, it was flucloxacillin, which is sort of the European version of oxacillin. And what they found was that despite the fact these patients were not getting vanco, right? They were getting flucloxacillin, they were getting a beta-lactam. Nonetheless, those who had a higher vanco MIC had worse outcomes. Why is that? Because who has a higher vanco MIC? It's a patient who's been exposed to lots of antibiotics in the past, who's likely has been hospitalized. In other words, it's sicker substrate. So it might not actually be the MIC itself that's associated with worse outcomes. It might be the kind of patient who has a high vanco MIC. Now, for some reason, you can't use vancomycin. What are your alternatives? Excuse me. The recommended first-line alternative is daptomycin, and that's because we have a randomized controlled trial comparing vancomycin versus daptomycin for patients with very serious infections, so Staph aureus bacteremia and endocarditis, and they found that daptomycin was non-inferior to vancomycin. That's why the guideline recommendation is that if you can't use vancomycin, daptomycin is your next go-to agent. What about some of these novel beta-lactams, these so-called 5th-generation cephalosporins that do have MRSA coverage? Are these possibilities? So we actually are getting some more data on it, and it looks pretty promising. So this first study over here is a retrospective analysis, 270 patients, MRSA bacteremia, 83 treated with ceftaroline and 187 with daptomycin. Ceftaroline is available inside the United States, so it is an option for us. And the good news over here is that ceftaroline on this observational retrospective analysis appeared to be as good in terms of composite failure, recurrent bacteremia, 30-day mortality compared to daptomycin. Daptomycin, no surprise, was associated with more CPK elevation, and ceftaroline was associated with more rash, so pretty predictable. There is a new kit on the block that's not yet FDA approved inside the United States, and it's called ceftobiprole, and it's another 5th-generation cephalosporin that is active against MRSA. This was just published in the New England Journal, and again, here we have a randomized controlled trial with Staph aureus bacteremia in which we are able to demonstrate equal treatment success with ceftobiprole compared to daptomycin. So as soon as this becomes available inside the United States, I think this is actually going to be a very compelling option because of the benefits of beta-lactam therapy in terms of both tolerability as well as microbiological effectiveness. So keep an eye out for that potential option for your future vancomycin ineligible patients. Is there value to adding a second agent? In particular, should we add rifampin for our patients with Staph aureus bacteremia? We have randomized controlled trial data on this, 758 patients with Staph aureus bacteremia, randomized to standard therapy plus rifampin, shown in red, or placebo, and overall they found actually no difference in treatment failure or death. So standard of care is not to add rifampin. There's certain special situations where ID might recommend it, typically in a patient who has retained prostheses, but that's a specialty situation that your ID consult will advise you upon. Now, let's talk a little bit about echocardiograms. We've spoken before about the value of an echocardiogram and its association with better outcomes for patients because it gives you diagnostic clarity that you can use to know does the patient require surgery or not, does the patient require an extended duration of therapy. So it's helpful in terms of really influencing your management. But is a transthoracic echo adequate, or do you need to put the patient through a transesophageal echocardiogram to get better resolution? So because it's such a common sort of clinical question, there are now a number of prediction rules about the presence or absence of endocarditis that inform your necessity of getting a transesophageal echocardiogram or not. So here's 3 different prediction rules that have been published. I've shown to you the different components of each of these rules, the positive rule, the predict rule, the Verster rule. And basically, the more stuff you put inside the rule, the higher the sensitivity and the higher the negative predictive value. Some of these, as you can see, get to very high negative predictive values and might be sufficient to allow you to forego the use of a transesophageal echocardiogram. But there's a lot of components that you need to take into account in order to make that. I just want to highlight a couple of the predictors over here of the presence of endocarditis that are highlighted by these different prediction rules, because I think these are useful to know. So the first one I'm going to highlight over here is the presence of an artificial device inside the body, particularly an ICD or a pacer. That really does increase the probability that the patient has an endovascular infection. The second one I want to highlight here is sustained duration of bacteremia. So if you have multiple days of positive blood cultures, particularly in the presence of antibiotics, that's a real clear indicator that you have an endovascular infection and should have a very high suspicion for endocarditis and get the TEE. The other thing I want to highlight is the presence of emboli. So if the patient has splenic abscess, liver abscess, bone and soft tissue infection, in addition to their positive blood cultures, that's a good sign that you might be dealing over here with an endocarditis and would have a very high suspicion in those instances. So these rules are useful both in terms of being able to decide whether to get a TEE or not, but also in terms of highlighting for us the risk factors for the presence of endocarditis. An interesting sort of situation is a patient with nosocomial Staph aureus bacteremia. In other words, they came to the hospital and had negative blood cultures, but sometime into the hospitalization, they develop an infection. And it's a special situation because, of course, we know more or less typically when those infections began. And so with that in mind, you can use that to inform your management choices with that individual. So this is a prediction rule focused on patients with nosocomial Staph aureus bacteremia and says that if the patient has any of these 5 factors over here, they echo what we said before in terms of risk factors for endovascular infections, so sustained bacteremia, intracardiac device, being on dialysis typically means there's the presence of a line, spinal infection or osteomyelitis, so in other words, a metastatic foci infection, then there is high concern for endocarditis. The patient needs a TE. But if none of those is present, they say TE is not necessary. Here's sort of an interesting opening area inside of endocarditis management, which is the role of PET scanning. Now, this is not sort of standard practice yet, but there is emerging evidence that a PET scan in a patient who has Staph aureus bacteremia can really add some useful information. So check out the study over here that took 149 patients with Staph aureus bacteremia who were referred to for PET scanning and to 151 matched controls with Staph aureus bacteremia who did not get PET. And what you can see over here is shown in red, basically, is patients who were not suspected to have a metastatic focus of infection, but were found on PET to have a bone and joint infection or a skin soft tissue infection or a muscle infection, so on and so forth. And what's surprising is just the sheer number of additional foci of infection found in this population. So it really does appear to increase your yield and to know what additional sites might be infected, which in turn might require either source control, so drainage of those infections, or the extra attention to duration of therapy. What was even more sort of striking about the study was that it also seemed to be associated with a mortality benefit. So here's the 9-day survival curve, and those who got FDG PET had a higher survival compared to those who did not. So it's not yet in the guidelines, but this is sort of an interesting possibility that we might see forthcoming in future iterations. On the topic of sort of working up patients who have an unknown source, I just want to make a quick aside over here to a study I just thought it was quite enjoyable. I want to share it with you. This is asking the question of utility of a CT scan of the abdomen in a patient with sepsis of unknown origin. So this was 218 patients who were diagnosed with sepsis of unknown origin in a large hospital in Taiwan. And so they excluded patients with obvious signs of a focus, those who had abdominal symptoms, if they knew that they had additional foci infection before CT, or if they felt there were clear non-infectious explanations for fever. So you're really honing on a patient's population who you're pretty sure has infection, and you have no sort of guiding clues as to where the infection might be. In that very select population, CT of the abdomen was positive in 64% of cases. So 2/3 of the time, they actually found something on CT. Liver abscess, pyelonephritis, cholangitis, those are some of the number one best players, but also non-infectious conditions. So inflammatory conditions like pancreatitis, aortitis, mediastinitis, new or progression of cancer. So not quite the topic of our analysis today, but does bespeak the value potentially of getting a CT scan if you don't know what your patient with probable infection has. Let's go back to our case study. So you go ahead and get a transthoracic. It shows decreased ejection fraction, as you knew from the get-go. Moderate mitral regurgitation, no veg in either the AIC leads or valves. A TE, though, does confirm the presence of a 1.2 centimeter vegetation in the mitral valve, so you were wise. You did not trust your transthoracic. You were concerned by the presence of moderate mitral regurgitation. There might be a problem. You appropriately went on to get a TEE. They did not see vegetations on the AICD leads, but the AICD generator and leads were removed given sort of the seriousness of the infection. And next question is going to be, how long should we treat for? And the answer, of course, as always, it depends. So some syndromes we know require longer duration of therapy: endocarditis, osteomyelitis, septic arthritis. A patient in whom you cannot get source control, so an undrainable abscess or a prosthetic device that cannot be removed, or a severely immunosuppressed pathogen. But we also know it's pretty immunosuppressed host. But Staph aureus has been one of those players where, in contrast to our data on gram-negative bacteremia, where we have increasing trial data showing that short courses are adequate, so 7 days, Staph aureus is kind of a holdout where we still ask for longer courses of therapy. And the question is that actually necessary? So first of all, let's take a look at the data on gram-negative bacteremia. We have multiple randomized trials now showing that 1 week is as good as 2 weeks for gram-negative bacteremia. Here's just one example. There are multiple like that. Here's another study showing the same thing, that 1 week is as good as 2 weeks for patients with gram-negative bacteremia. What this study adds is that in addition to a 1 week course or a 2 week course, they also tried a CRP guided course, or a biomarker guided course to determine duration of therapy. Now, I've shown for you over here the distribution of duration of therapies amongst patients who are randomized to CRP analysis. Basically, check CRP every day. When the CRP drops below a critical level, you can stop. And what's interesting about this is it shows really sort of a distribution of durations of therapies, and that with CRP, they were able to get some patients down to just 5 days of therapy, and some patients required a good bit more than 7 days of therapy. And I think to me, this speaks the individuality of patients, that although we often speak in the guidelines say 1 week or 2 weeks, or whatever the case may be for this condition, I do believe that there's room for customization, taking into account patient particularities. And this is sort of one direction that could show that. There's another trial coming out, by the way, later this year, hopefully, looking at a randomized for patients with sepsis of routine care versus procalcitonin to guide duration therapy versus CRP. So stay tuned for that particular trial. Should be released sometime towards the end of the year. How about Pseudomonas bacteremia? Again, 1 week versus 2 weeks. We don't have a randomized trial. We do have a propensity-based analysis. 1 week is as good as 2. So for gram negatives, we feel pretty comfortable that 1 week is as good as 2. I'm going to circle back to Staph aureus question, though, in a moment. But I first want to ask about, is there value to getting follow-up blood cultures? Let's check it out over here. So this is a meta-analysis of 15 observational studies looking at the association between getting follow-up blood cultures and mortality in patients with gram-negative bloodstream infections, and obtaining follow-up blood cultures was associated with a lower risk for death, and positive follow-up blood cultures, no surprise, was also associated with higher risk for death. Well, this study would argue that there is importance to getting follow-up blood cultures even for gram-negative bacteremia. Once you are going to treat, should you go ahead and place a PICC line? So here are the guidelines that come from our friends in Michigan who put together the so-called MAGIC guidelines on the appropriate intravascular devices for different kinds of indications. And they suggest choosing your intravenous device based upon duration of therapy. So if you're using less than 5 days of therapy, a peripheral IV. 6 to 14 days, a midline is adequate. More than 14 days, that's the only subgroup in whom you might need to go ahead and get a PICC line. And the reason this is important is that the complication rate of PICC lines is high. Here's one analysis of that. So 20% of patients develop obstruction of the PICC line, thrombosis in 2%, infection in 9%, lots of problems. We do have randomized trial data looking at the difference in complication rates with PICC lines versus midlines. I'm sorry, this is not randomized. This was an observational analysis. And what you can see over that PICC is clearly associated with a higher risk of adverse effects compared to a midline. So if your patient requires less than 14 days of antibiotics, we do strongly prefer that you get a midline. Perhaps even better than a midline, though, is to forego a line altogether and try to treat your patient with oral. So is that a wise and defensible approach to take? So here we go. Turns out it's not a new question at all. Even this study here was done back in the 1980s, and already there was data at that point on the potential benefits of oral therapy for very severe bloodstream infections. So this was 14 IV drug users with right-sided Staph aureus endocarditis, and they were treated with oral ciprofloxacin plus rifampin, and 10 completed therapy and all were cured. So we actually have a long history showing that orals are potentially useful, but now we enjoy a lot of good data to support that as well. This one over here is looking at Staph aureus bacteremia and asking the question, can you make an early switch to orals for Staph aureus bacteremia? And the way they did this study was 213 patients with uncomplicated Staph aureus bacteremia were randomized to orals versus IV antibiotics after a 5 to 7 day induction period of IV. And all patients got a total of 14 days of treatment. The usual oral choice over here was trimethoprim sulfamethoxazole or clindamycin. And basically the bottom line over here was that they both worked equally well. So this would suggest after a 5 to 7 day induction period for uncomplicated Staph aureus bacteremia, you can indeed make the switch to orals to facilitate an early discharge or to facilitate an easier outpatient treatment course. I did put up here on the slide, though, how they define uncomplicated, because it was pretty strict. You can read through the list over there of yourself, but basically no signs or symptoms of a deep-seated infection, so no endocarditis, no pneumonia, no infected implants, no osteomyelitis, no empyema, blah, 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 so on and so forth. In other words, it was a very restricted population who they were able to use the strategy. But if you have none of these potential signs of complications, then a quick switch to orals probably works fine. How about more long-term data? So this was the now famous POET trial, looking at partial oral versus IV antibiotics for endocarditis. And the way this one worked was that you had a 10-day induction period with IV therapy, and thereafter you randomized to an oral regimen versus an IV regimen for the rest of your treatment course, typically on the order around 6 weeks. I've listed for you over here the oral regimens that they use. And what I want to point out to you is that these are very high doses. So amoxicillin is 1 gram 4 times a day, plus rifampin 600 twice a day. Likewise, dicloxacillin 1 gram 4 times a day. So, and they basically found, as you probably well know by this point, equally good outcomes with both the oral or the IV sustained treatment courses. But the message over here is that if you are going to go this pathway, you really need to be attentive to dose. And the doses are very high. They can be difficult for patients to tolerate. Probably the best tolerated regimen is using the Nasalid plus moxifloxacin. So that might be my go-to, provided the patient does not have contraindications to the use of either of those agents. And of course, the benefit over there is that you can get high levels of the Nasalid inside the blood, with oral dosing, with just twice a day dosing, compared to these sort of possible 4 times a day kinds of regimens. So that's all very well for trial data, but what's the real world experience with the use of orals? So here's an interesting study from Barnes Jewish Hospital in St. Louis, where they focus on people who inject drugs, who are hospitalized with complicated Staph aureus bacteremia, things like endocarditis, vertebral osteomyelitis, septic arthritis, epidural abscess. And they looked at the duration of therapy in terms of IV with no orals, IV with partial orals, or standard care. And the outcome we're going to look over here is microbiological failure within 90 days. So let's start with those who got standard of care, basically IV treatment for their full duration of therapy. Here's the rate of microbiological failure. You can see it's very low. For those who got partial IV treatment, meaning that less than 10 days worth of treatment and no oral therapy, so a very short course of IV, no oral tail, a very high rate of relapse. So that clearly is not a good treatment strategy. If you were able to get some orals into that person, again, even if only less than 9 days, you substantially decrease the rate of relapse, but you still have 50%, so it's still very high. But if you're able to get a decent quantity of an oral tail into those patients, then you are actually able to get down to pretty low rates of relapse. So this actually affirms that in real world settings, even with a challenging patient population, those who have a history of IV drug utilization and complicated Staph aureus infections, that even if you can only get partial IV treatment and you transition them to orals, so long as they continue to take that orals for a decent period of time, ideally 6 weeks, that is associated with decent outcomes. I do want to throw up a big caveat over here about trimethoprim in particular, because we do have randomized controlled trial data looking at trimethoprim versus Vanco for serious MRSA infections. And while overall there was no difference in treatment failures, amongst those who had bacteremia with MRSA, the treatment failure rate was higher with Bactrim compared to vancomycin. So that's not my preferred choice. They did use an appropriately high dose of trimethoprim, so it does not appear to have been the explanation for this. So I think some other choices for your Staph aureus bacteremia, other oral choices might be preferable, and linezolid again might be the most realistic of those, again, provided your patient doesn't have a contraindication to that. So if I can summarize some of the points we've discussed today, one drug is sufficient for Pseudomonas bacteremia once susceptibilities are known. Carbapenems are preferred for ESBL bacteremia. Cefazolin is a drug of choice for MSSA bacteremia. Vanco and Dapto are the drugs of choice for MRSA bacteremia. We'll look out for those 5th generation cephalosporins once they become approved inside the United States. High Vanco MIC is associated sometimes with outcomes, but it's probably the patient, not the drug. Get a TEE for community onset Staph aureus bacteremia. If you have multiple days of positive blood cultures, if you have a device in place, structural heart disease, IV use, hemodialysis, or emboli. Treat uncomplicated gram-negative bacteria 7 days. Staph aureus requires longer courses, and oral agents for endocarditis seem to be just fine. After you've given a week or so of induction with IV, make sure you dose appropriately at the appropriate oral dose. And PICC lines are associated with a very high complication rate, so save your patient from them. Use those orals when you can. Midlines for shorter courses of therapy when you can, and throw out those PICCs all together. And with that, I'll stop and be happy to take your questions.
Perfect. Thank you, Dr. Klompas. We have a number of questions, many of which are about blood cultures. So I'm going to try and put them in order and give them to you. The first one is, if you have a positive blood culture, who needs repeat cultures? Does that differ if you have gram-positive or gram-negative bacteremia? And when can you stop culturing them?
Yeah, good question. So the non-controversial answer to that question is everybody who has gram-positive bacteremia, Staph aureus, for enterococcus, they do absolutely require getting repeat blood cultures, and you need to continue until those blood cultures basically are negative. For gram-negative, there's much more debate inside the field. Many say you don't require for gram-negatives, particularly if you have a clear sort of source of diagnosis and it's been appropriately managed with appropriate source control. But I did share with you that meta-analysis suggesting that getting repeat blood cultures in patients even with gram-negative bacteremia was associated with a lower mortality rate. So I think that's a bit of an unanswered question at this point. I'd say in general, I lean towards getting them, except for the simplest of cases.
Perfect. And practically speaking, because we all know that there's currently this shortage of blood culture bottles that we are all dealing with, are there times where that would change your practice, particularly given this current constraint?
Yeah, so that's a great question as well. So for the patients with gram-positive infections, again, Staph aureus being a real highlight over there, it just it really is important to get serial surveillance on those patients because they are such a high-risk population. But it doesn't mean you have to do it every day. So while a traditional practice is 2 different sets of blood cultures every single day, that's probably not necessary. So every couple of days, 2 days, 3 days, what have you, might be fine. You can sort of calibrate that according to your particular patient. So do still get follow-up blood culture, but you can decrease the frequency. And then, as you said, with gram-negative pathogens, there is more room for debate and flexibility over there, and a lot more debate in the field. And that's where you can, I think, be pretty circumspect or more circumspect about who requires them or not.
Perfect. And then the other one is about if we have somebody who we're concerned about and the timing of blood cultures and yield, specifically surrounding, is it higher yield to get the culture with a fever? And does that change if you have an immunocompetent versus an immuno-incompetent person?
Yeah, a very, very, very good question. For bacteremia, I haven't seen convincing data that makes a difference. What I have, what my experience is though, is that in practice, sometimes just getting blood cultures at any time can be difficult. That from a logistic point of view, getting the phlebotomist or nurse or physician to actually draw those blood cultures is probably the greater barrier. So I'm happy to get blood cultures and don't worry so much about the exact timing in order to when they're obtained. The one caveat is we did speak about in the beginning about the importance of getting a blood culture before you administer antibiotics. That really does make a meaningful impact on the ultimate yield of your blood culture. So that is worth doing. If you have to delay your antibiotics 20 minutes or half an hour to get that, I do believe that's a price worth paying.
Perfect. There's a question here about kind of if you are in a scenario where you have bacteremia and you cannot get a TEE, how does that affect kind of your treatment decisions in terms of, do you just make a decision to treat for prosonitis even if the TTE is negative?
Yeah, good. So if you have a what do you get from getting a TEE? So you can get diagnostic clarity, and you're looking to ask the question: does a patient actually require surgery? And that's because the indication for surgery being the presence of basically an abscess. So a prosthetic root access, a valve root abscess, or does a patient have a massive vegetation, or does a patient have severe valvular dysfunction? The good news is that you can actually answer most of those questions with other modalities. So a transthoracic will certainly tell you if you have a giant vegetation present. It'll tell you if you have severe hemodynamic dysfunction, so wide open mitral regurgitation or aortic regurgitation. So from those points of view, you don't necessarily need to get the TE for that. So a transthoracic showing that you don't have a giant vegetation and you don't have severe valvular dysfunction actually can be pretty reassuring. So if you have then a compatible scenario, the patient has a compatible pathogen inside the blood, you have sustained bacteremia, you have embolic foci, the patient's high risk by virtue of having implanted metal devices. I think it's actually pretty reasonable to say that the TE is not going to change your management. Treat that patient quickly for presumptive endocarditis, give them a full 6-week course, and don't sweat it. The other angle to this is that there are other modalities besides TE you can use to get a further look at some of these questions. So cardiac gated CT and PET and MRI are the additional options that you might be able to consider depending upon your institution and your need.
Perfect. And then maybe the last question I'll pose is, given what we learned about procalcitonin and bacteremia, how do you think about ESR and CRP, and do those have a place?
Yeah, so I showed you a little bit of data on the value of CRP for determining duration of therapy in patients with gram-negative bacteremia. It's showing that just like setting a fixed 7-day or 14-day course, that a CRP-guided strategy was associated with equally good, if not better, outcomes. So I think we do have evidence to support that. I've not seen anything equivalent to that for ESR. from a theoretical basis, I doubt ESR is going to be as useful as CRP or procalcitonin because the ESR is much slower to change over time. Whereas the CRP, because an acute phase reactant, we'll see changes on a much more day-to-day kind of a basis. So CRP is preferred. In terms of CRP versus procalcitonin, stay tuned. There is a randomized trial that will be sort of reported on at the end of this year, early next year, that compares nothing versus CRP versus procalcitonin to guide duration of therapy.
Perfect. That sounds great. I think our time is up. We thank you sincerely for these two wonderful talks.